by engaging staff, having them think about what needs. And we have lots of other examples in which you can find in the appendix. Recommendation number 3 is implement nurse residency programs. And every other health professional has residencies. Pharmacists have a residency program. Physical therapists have a residency program. Physicians have a residency program. A transition into practice. You can't take your knowledge that you get in 4 years and say, boom, I can practice. You know, you need a transition program. And we had evidence again, strong evidence, some of my research, certainly Dr. Aiken's research, Dr. Kovner's research, that demonstrated that if you had more nurse residents in your had nurse residency program, you actually decreased the incidence of hospital-acquired conditions. Now, that used to be not something that people were concerned about. But now, you know, October 1 this year, CMS says, you know, if you have falls that are below that are above the median, or you have hospital-acquired pressure ulcers, or you have any of those nurse-sensitive measures, you will have your payment from CMS reduced. Now everyone all of a sudden is listening, right? You will have your payment reduced. Originally it was going to be up to 50% in hospital-acquired condition. They reduced it. They kept it at 50%. They took patient satisfaction was going to be 50%. They reduced that to 30%. But even with that, patient satisfaction, you know what the number one factor in terms of patient satisfaction is? The relationship between the nurse and the patient. The relationship between the nurse and the patient. And so, starting October 1 is the base year, so October 1 to 2011 to September 30th, 2012. If your patient satisfaction scores are below the median, then you will not get up to 2% less payment. 2% less payment, may not sound like a lot of money? That's a lot of money. You know? So, all of this is about, well, what types of things affect patient satisfaction? Well, if you look at the research, it says if you have a more educated and more engaged nursing workforce, you will decrease the incidence of hospital-acquired conditions and you will increase patient satisfaction. So, it's not just true of pre-licensure nurses. When we say transition programs, we mean transition. So if you're a new nurse practitioner, you need to transition. If I would, as a, you know, my background is perinatal, and I was a clinical nurse specialist, you know, worked as a clinical nurse specialist for 10 years. But I couldn't take my clinical nurse specialty. The Federal Trade Commission, and we did get a first valley of shots on that one. The Federal Trade Commission is, at this point in time, reviewing the state of Florida. It's the first state they're going after. Restriction of trade as it relates to advanced practice nurses. And they have filed that suit to be able to allow those advanced practice nurses to be able to function in accordance with their education, because they're certainly prepared to be able to do that. The second recommendation is expand opportunities for nurses to lead and diffuse innovation. We found so many innovative practices across the United States. Wonderful examples of nurses working with other team members. You take the state of Pennsylvania, Governor Dow, before he maxed out, turned out, was very supportive and worked with both the University of Pennsylvania as well as Drexel University and the University of Pittsburgh. All had a variety of nurse-managed programs in primary care. And because they were able to reduce their Medicaid costs by 14% over 3 years and have it sustained, she said, absolutely, I want to support the nurses. Innovative ways. But how do you scale it up? How do you scale it up? We found wonderful opportunities to eliminate obesity in parts of the country. Wonderful program in University of Mississippi, again, nurse-led. Part of the Jackson Heart Study, so some of you know the Jackson Heart Study, the longest running cardiovascular study. What you don't know is, it's that old fishing story. I'm a fisher person. And so, I'll tell you a quick story about a lady who was fishing, and every now and then she'd pull up a body. And so she roll over to the shore, throw the body on the shore, and go back to fishing. After the third time, someone on the shore said, Hey, why don't you go upstream and find out who's throwing them in? So public health story, right? You go upstream and find out who's throwing them in. Well, that's what we mean by childhood obesity. If you can address childhood obesity while they're a child and address the issues of trying to help them make right choices in terms of their activity levels as well as their nutrition intake, you can reduce the prevalence of heart disease in populations, and particularly working with males. So I'm going to be one of those individuals cheering on Dr. Audwin Fletcher, who will be coming in as a member of the Academy this year for his wonderful work that he's done with African American males between the ages of 6 and 12 to get them to take on this issue. Nursing. Dr. Fletcher's a nurse. Okay? And so this, how do you diffuse that? How do you provide the opportunities for nurses to lead and diffuse these type of collaborative efforts? How do you take what we did, I had the honor of chairing for 4.5 years of transplant care at the bedside work. We started with 10 hospitals. Those 10 hospitals, which we published in not just the American Journal of Nursing, we published it in JAMA, and we published it in New England Journal of Medicine, and we published it in Health Affairs, that showed that if you gave frontline nurses the ability to come up with ideas, to change the practice environment, guess what? It works, and guess what? It was cheaper. So they, having the nurses come up with the idea of asking family members, do you have a scale at home? Your loved one is going home with congestive heart failure. And we wondered why we were getting so many patients bouncing back in at 7 days and 30 days in congestive heart failure. And you give them an instruction, weigh yourself, they live. No one asked if they had a scale. And a large majority of them didn't have a scale. No one told them about how to read a label. So just because you didn't add salt, sometimes it's what's in the food that was already salt. Staff nurses came up with that. Staff nurses in institutions demonstrated that they could reduce the readmission rate. We reduced the readmission rate in those 10 hospitals over the 4 years by 17%. Okay. And perinatal, and go work in a critical care. I would need some type of transition. So it's transitioning across. Back to my formula of could we flip it? Could we put 65% of the nursing workforce in community? No, not today. They're not prepared. They're not prepared. We would have to, you would have to, schools would have to prepare the nursing workforce. Most of what we prepare the nurses to do is to pass that test, right? Get licensed. And it's based on the acute care model. So we would need to change that and reframe that. So we need nurses and leaders from academia and service to work together to establish more of these transitions and practice models. It's a wonderful opportunity. It is a public safety strategy. We have seen transitions into practice models in long-term care and community health and in school health. And where they exist, you get better clinical outcomes. Recommendation number 4 is to increase the proportion of nurses with a baccalaureate degree or higher to 80% by 2020. Right now, 50% of America's working nurses hold a baccalaureate degree or higher. So the difference is 30% that we need to increase. We think we can get that done by having more innovative programs. And those innovative programs, when I graduated, I'm one of those individuals who went directly from a baccalaureate to a master's program. And I got noodle whipped a lot about that, oh, you're not gonna know anything. And I worked while I was working on my master's. Even if I hadn't worked working on my master's, I was continuing to acquire knowledge about human care. The key was, when I got into the setting, individuals being able to help me, learn how to apply that knowledge, right? It's the same thing about the gap in terms of the production of research and the use of research. That 17-year gap, which we cited in our publication, we need to reduce that 17-year gap from the generation of knowledge to the application of knowledge. And we need more nurses with at least a baccalaureate degree to do this. We think in terms of the who, we have to we must partner with accreditation bodies, private and public funders, the Funders in Health, which is a group of all the health foundations in the United States who provide any type of support for health, have agreed to take this on, okay? So they're waiting for people to bring them proposals about how do you help move this nursing workforce so that it is better prepared. Recommendation number 5 is to double the number of nurses with an earned doctorate. The number, we've been talking about nursing shortage for donkey years. The first nursing shortage, who knows when the first nursing shortage was? 1903. All right? In the United States. 1903 in the United States. So we've been trying for 108 years to address the nursing shortage. Now, we didn't have a national nursing sample survey in 1903. So where does this come from? It comes from, and I'm not a nurse historian, so Julie Fairley shared this with me, and she is a nurse historian from the University of Pennsylvania. It has to do with the way they count it today, which I think is the wrong way to count it. The way they count it has to do with the vacancy rates in healthcare settings. That's how they count and determine the shortages. In actuality, that shortage in 1903 had to do with the health problems that were occurring in 1903, and the fact that there were insufficient numbers of people to deal with those infections. And so there will always, my point in this is there's always going to be a nursing shortage, But we can do some things to be able to address it. And the number of two factors are contributing to it. Why schools of nursing can't take more people in has to do with the faculty shortage. And so it's a pipeline issue for us. To have more faculty, you have to have more individuals who got a baccalaureate degree, and either went baccalaureate to doctorate or baccalaureate to master's to doctorate. That pipeline doesn't exist because we don't have enough people with baccalaureate degrees and master's degrees, and we don't have enough people graduating with doctorate programs. So we need to double the number of nurses with an earned doctorate. I don't care what that doctorate is in, except, and there's not everyone on the committee can agree to this. One of the things that you work on consensus. That is, can you live with the recommendation? You may not, like it, and you didn't get 100%, but can you live with the recommendation? And so there was some thought about we should say nurses, double the number of nurses with earned doctorate, but only PhDs. Now, my doctorate happens to be in public health. That would shut me out. And there are a lot of nurses who have EDDs, right? And nurses who have BNSCs and all kinds of other doctorate degrees. But basically, we need to have more nurses who earn doctorates, not just because of faculty. That was the number one driver. And, the second reason we have turned away 133,000 people who sought to get into nursing schools is faculty shortage and clinical placement. So, goodness gracious, even though we're not taking anybody to the moon anymore, isn't that sad? I'm so sad the program is closing. We have so much innovation in this country. We found lots of different ways for people to learn, right? And so we think that there needs to be more folks generating different ways to learn. And so we need more scientists. We need more nurses in executive practice with earned doctorates. So it's not just for the faculty, but we believe that if we increase the number of nurses who serve in faculty and nurse researchers, with increasing need for diversity. We haven't gotten very far. We have increased the number of men in nursing, not as much as we would like, but it has increased. But we really have not done anything in relationship to Hispanics. Hispanics are the fastest growing ethnic group in our country, and they're almost flat between the 2004 and 2008 survey. African Americans haven't increased in that, and Asians have always been more than what they represent in the United States population. So increasing that work, the number of nurses, the diversity of the nursing workforce, not just at the pre-licensure level, which is where most of the work has been done, but also at the doctorate level.